Manual therapy. Get to know and understand the most efficient techniques for your patient's pain relief and recovery. Have you ever wondered what the most effective manual treatment methods are to get patients out of pain? In this episode, we dive deep into a discussion of manual interventions that expert clinicians use to handle cases from early in rehab all the way through to the transition of performance. Elevate your skills for your patients with this podcast. So, to start things off, why do we need to use manual therapy? It depends on who you ask, honestly, right? There's different camps of like manual therapy is completely garbage and manual therapy is the best. It's the only way to go. There's people that all they do is manual, and there's people that don't do any manual at all. And just like with most things, the answer lies somewhere in the middle. Now, I've done a residency and 2 fellowships that were heavily based in manual therapy. Early on in my career, I would do manual therapy for everyone. Maybe it was a little bit of ego, and I was like, oh yeah, I got magical healing hands. Look at all the things I can do. I'm gonna fix you with my hands. And that's just not the way that it works. However, it is very important to understand the concepts around what's happening and being able to evaluate when somebody would benefit from it. And you could argue all kinds of things for manual therapy, and you can argue all kinds of things against manual therapy, right? The number one thing manual therapy is great for is reducing patients' pain and improving mobility. Even if it's a short-term improvement, as long as you capitalize on the short-term improvement with something that's going to now have that carryover to be a long-term improvement, right? What does manual therapy actually do? Right? A lot of it is a nervous system downregulation. That's why dry needling and cupping and massage and mobilization, manipulation, all those things, they all work on similar pathways through the body. Yes, you'd argue with needling that, there's some other things that happen because there's a needle entering and there's blood flow and there's actual tissue damage and all that stuff. And I wouldn't disagree with you. However, when I use needling for manual therapy, it's just to save my hands from a different way I would do it, right? That's why so many people get results with all of these different things, because it's all just different ways to neuromodulate and downregulate the nervous system, decrease that pain response and that threat perception, and then ideally get people moving, right? If you can do something that's nice and reduces somebody's pain and you don't do it, personally, I think that there's an ethical issue there, right? Imagine that you took your parents, your mother, right, your grandparents, whoever you really care about, to go see a healthcare provider, and they had something in their toolbox that they could do on the spot for them to give them a 50 or an 80% reduction in pain. I just made those numbers up, right? But they didn't do it because they felt like, well, patients need to move and manual therapy is useless and there's no long-term carryover. Would you be upset if you found out that they could have done that and they did not? Or if you were going somewhere and you were in a lot of pain and they could do something to temporarily decrease your pain on the spot, would you appreciate it if they did it? Hell yeah, you would. As long as they're not only doing things that give you temporary pain relief, right? Because nobody wants to be stuck in the cycle of temporary pain relief, pain comes right back. Temporary pain relief, pain comes right back. Because we're not doing the things after it that we need to be doing, and we're not providing the patients with the education to be in control of their own pain and empowering them to be able to do these things on their own, right? So building therapeutic alliance, decreasing pain, being able to progress people into tolerating more movement-based interventions early on, right? Improving their mobility and their joint mechanics so they can move better and we can reduce the compensations, the faults, and the deficits that they have, right? Those are all great uses of manual therapy, right? And it works on different, mechanisms through mechanoreceptor stimulation and A beta fibers and the gate theory, and it does all of that stuff, right? So when is it really appropriate, right? Anytime that you clinically deem that it's appropriate, it's appropriate. Now, there's some guardrails on that, right? Like if somebody comes in and they have pain with back squatting 400 pounds and that's their only time they have pain, Do you think that manual therapy is appropriate there? Maybe. Depends on the context and what you find, right? You might find that they have an ankle dorsiflexion restriction that's leading up the chain to having a butt wink at the bottom that's then causing their pain. It would be appropriate maybe at that point to mobilize their talocrural joint, right, to increase their dorsiflexion if you found that that was restricted, and then retest their squat. And then if they can squat better with less pain or no pain after doing that, then we teach them to do it themselves, right? And then yes, the answer to that is it's appropriate in that situation. Now, if they come in and they have back pain with squatting 400 pounds, you find dorsiflexion restriction, and you start doing lumbar paraspinal soft tissue, unless you found that that is a contributing pain generator, maybe not so appropriate, right? So you have to have this clinical reasoning behind what you're doing and have a specific reason. One time when I was a student, it was my third clinical rotation, I was told that I needed to have every single one of my knee patients on the table doing patellar mobilizations. Is that appropriate? Absolutely not. Some of these people's kneecaps moved around a lot, right? And I was like, well, here's some context. It was like my little review there, right? And they had just finished telling me what a great job I do building rapport and relationships with patients. And then they told me I needed to do manual therapy, knee mobs for all the knee patients. When I asked them why, they told me to build rapport with my patients. And I was like, well, it's maybe not the best reason to do it. And you just told me that I already do a really good job at that. So like, why do I need to do it? And they're like, well, that's just what we do here. Okay, got it, right? We'll check the box. I'll play by your rules. But that's not a good reason because it's what we do here, or to just build rapport, right? Like, how about you listen to your patients? You understand them. You make them feel heard and cared about, and then you help them solve their problems in a meaningful way. That's a really great way to build rapport rather than wasting their time and their money doing something that they don't need, right? So when do we actually mobilize joints? And that is a great question because there's many different schools of thoughts, right? You've got grade 1 and grade 2 mobilizations, and you've got larger amplitude, smaller amplitude. And in general, I mobilize and I teach clinicians to mobilize joints when there is a reduced range of motion in a firm end feel, a firm capsular end feel, right? You can certainly do some mobilizations for pain reduction, right? If somebody has a very stiff, painful thoracic spine, I wouldn't go doing really hard mobilizations getting in there doing grade 4, right? They might only tolerate a grade 1 or grade 2. And in that case, yes, you do a grade 1, you do a grade 2. You do small, right? Small, slow mobilizations, very short periods of time to desensitize and down-regulate the nervous system so they can tolerate actually getting to the point where you can then improve the real mobility of the joints so they can function better, right? If somebody has shoulder pain and you're coming in and you're like moving their shoulder around, just grabbing it, and you're like, oh yeah, I'm doing this for pain reduction, that's a waste of time, right? There's no reason to do that. If there's no restriction in the joint, you don't need to mobilize it. If somebody has pain in their shoulder and you're just moving it around, you're wasting your time, you're wasting their time, okay? So if somebody has a reduced range of motion and a firm capsular end feel, then you mobilize it. But Doc Raj, when should I manipulate? And that's a great question as well. A lot of people just like doing manipulations. They're fun, they're sexy, patients feel good afterwards. Again, it's your clinical reasoning of when should you manipulate. Now, the way that I look at it is if somebody has a stuck joint, right? If they wake up and they've got a crick in their neck or their back or something, they can't move, there's no ridiculous symptoms, and I find a very specific area of hypomobility, then I will manipulate that area and retest. It just kind of unsticks the joint. It's just a quick thrust to get the joint to open up a little bit, right? If you're closing your drawer, your kitchen drawer, and it gets stuck, what do? You wiggle it around, you open it up, and then it closes totally fine after that. Same kind of a thought process here, right? You could also manipulate somebody for the neuromodulation that happens, right? The Control-Alt-Delete, the reset of the nervous system in the area to down-regulate the muscle activation, all that stuff. And that's a great use of it as well. But again, I'm not doing that if there's no stiffness in the area. I'm not just randomly manipulating people. And there's plenty of people out there that'll tell you can't be specific with your mobilizations and your manipulations, and that's just because they're not that skilled, right? I've tested this a bunch. I've had other clinicians test it where they've identified an area of hypomobility that seems to be the pain generator and manipulated away from that area intentionally. And maybe the patient got a little bit better, and then by the end of the visit, it came right back. And then at the end of the visit, manipulate that exact spot. And like, oh, now it's gone. And then it stays that way if it's appropriate. You shouldn't have to manipulate over and over and over and over again. If you do, there's something else that's missing, right? Anytime I'm manipulating something, I'm then teaching somebody to stretch it themselves afterwards, right? So they're not relying on me as a provider in my magical hands. They're not going to manipulate themselves. Maybe they can, crack their back over a chair or something like that, but they're not going to take a joint to end range and then give overpressure with high velocity, low amplitude, right? Of pressure to then make that joint mobilize into ideally maybe a traction force if they're doing it themselves. Either way, it doesn't matter. But what they can do is sustained stretches, right? And it is so important to teach people to do this themselves, because otherwise they're relying on you to, quote, fix them, right? And you're not fixing anybody. What you should be doing, what I do, my opinion of what therapists should be doing, is teaching patients the tools and the education that they need to be able to take care of themselves, right? Especially if you're in the cash world and you're seeing somebody once a week, maybe twice a week. If you're trying to improve the mobility of something, you doing it for a couple of minutes twice a week is not going to make a big difference. But if you could teach them to do it themselves, and they can do it every single day, or maybe even a couple times a day, who do you think is going to get better results? The person that goes to their therapist, the therapist uses their magical hands and ego to fix them, quote unquote, right? Or the patient that gets taught how to take care of themselves and does it daily. Who's going to get a better result? Probably the person that has the tools, right? Person that can do it independently. They're going to be better, faster, and they're going to be more grateful because now they have that tool for life if that situation ever pops up again. So then, what are some heavy-hitting manual therapy techniques that I think everybody should know? There's quite a few that I think are very useful, but there's a handful for each body part that are really impactful, right? And if we want to talk about the spine first, I think being able to differentiate between, one, regionalize where the pain's even coming from in the cervical spine, right? With testing of where is the pain generator coming from, what region, and then being able to go in and segmentally localize where the pain is coming from is huge, right? So if we regionalize something to the upper cervical spine, is it coming from the occiput? Is it coming from C1? Or is it right below the upper cervical spine? It's coming from C2 movement. We need to be able to test each one of these things independently so we can directly treat the pain generator, right? So somebody is missing a dorsal occiput glide, right? Because we have a very forward society where we're always sitting, we're here, we're driving, we're like this, we're watching TV. We're always in this position where the occiput is now glided anteriorly. So a lot of people will get stiff gliding posteriorly, and that'll lead to a lot of cervicogenic headaches, right? And people just deal with the muscles underneath there. And a lot of times those patients don't get better. They get temporary relief and it keeps stiffening back up. Why do those muscles not really keep stiffening back up? Because the therapist is not dealing with the underlying joint. So being able to differentiate which segment it is, and then testing each side independently, and then at least being able to mobilize bilaterally, if not unilaterally, so you can direct all the force at the area that specifically needs it. Right? And then being able to test C1, super important, because you get literally half of your rotation of your cervical spine from the AA joint, right? From C1 on C2, because of the way the alar ligaments work. When you're rotating at about 45 degrees, the alar ligament gets taut and pulls C2 along it into rotation. But you get 45 degrees to the left, 45 degrees to the right rotation. That's 90 degrees of rotation from C1 alone. So learning how to assess and treat that specifically, huge, right? If you're missing half of your rotation from that single joint, or you're missing rotation to one side, you're missing 25% of your cervical spine rotation, and they have some irritation down below, do you think maybe that's going to be a contributing factor, right? Which then leads us into the thoracic spine, being able to assess and address the thoracic spine, preferably using a mobilization wedge and learning how to do that at least in the prone position so you can address those areas specifically, going to be a game changer. If somebody's stiff up top, they're stiff at the bottom or below, right above and below, and the thing in the middle, maybe they've got a mid-cervical radiculopathy, and that's irritated. What do you think is going to happen? The mid-cervical is now going to have to take up all of that extra slack, right? Which probably is going to contribute to it staying irritated. So if we can free up the things above, free up the things below, now, guess what? That mid-cervical spine has to do a whole lot less work and it can recover a lot easier. Just like the knee, right? If you're dealing with the knee, you should be looking at the hip and the ankle 100% of the time. Because the knee typically is just an innocent bystander of things going on above and below. And that's true for everything that you look at, right? If we look at some of the contributing muscles in the cervical spine, the levator scapulae, that knot that just never goes away that people have, typically due to a low-level nerve irritation that's not causing pain yet or currently, but that muscle goes into guarding. It's a big, long muscle that when the brain senses there's an irritation in the cervical spine, it will turn that muscle on and go into guarding. Same thing with the upper traps, because they're big, long muscles that come up from the shoulder, right, up to the occiput, levator scap, up to the cervical spine, and it just goes into guarding to try to stop movement. Much like if you broke your arm, we'd put it in a cast, right, to stop the movement. So what happens there? What does the cast actually do? It just creates an environment within the body that's conducive to healing. The brain tries to do the same thing, but maybe a design flaw there, because when muscles are overworked, what happens? They become sore and painful, right? And then clinicians will deal with the muscles, they'll do soft tissue, nice things, it keeps coming back, and they don't know what to do. Because they don't have an overreaching system of evaluation, and they don't understand those patterns, right? So levator scap, upper trap, the sternocleidomastoids, another big one in the cervical spine that'll go into guarding and become sore and painful, create some loading. Sometimes the scalenes, but I see a lot of clinicians kind of go overboard on the scalenes when they should be addressing those other muscles, right? When we look down at the lumbar spine, typically lumbar spine issues are more of a hypermobility issue, right? Because L5 is a natural hinge, and that's why there's so many issues around L5, because it moves more than the segments around it. So typically it's a movement error where there's too much going on, things get irritated. So we don't typically have to mobilize the lumbar spine. Sometimes you'll get some upper lumbar stiffness, but a lot of times what's happening is you're getting thoracic stiffness, and you've got stiffness above and stiffness below in the hip and or the ankle, right? That then the lumbar spine has to make up the extra movement. So again, going back and learning the thoracic spine mobilizations, checking out the hip, making sure you know how to do a posterior hip capsule mobilization, anterior hip capsule mobilization. Make sure you know how to differentiate between the psoas being the restrictor of the hip extension versus the anterior capsule, because you can address the wrong thing and not get anywhere, right? And the two seem pretty similar, but they're very different. And the psoas is often a huge problem in lumbar spine patients because, again, it's one of those big, long muscles that comes from L1 all the way down to L5. It connects directly to the anterior fibers of the discs of L1 through L4, not L5. And it runs down, right, anterior to the pelvis and then back posterior to the femur. And when the brain senses that there's some sensitivity in there, especially when there's an extension and a load sensitivity, that thing kicks on and goes into guarding, which then causes more extension and more load, segmental extension through the lumbar spine. So that's very important to know how to address and deal with. The quadratus lumborum, the QL, right? People that get pain in the back here, right over the SI joint. A lot of times that's from a QL going into guarding because it attaches down inside the pelvis in that region. When people have that one-sided low back pain. A lot of times it's the QL going into guarding, right? They side bend towards it, it activates it, it hurts. They side bend away from it, they stretch it, it hurts. They get that one little spot. You go in there, you palpate it, and it's like, ooh, one side's nice and pliable, not too tender. The other side feels like there's a bone in there. Maybe it's not tender if you're not poking at it enough, hard enough, or you're in the wrong spot. But if it's, you can feel the difference in the muscle tension, like we address it, that stuff tends to go away, right? So doing that, both of that, the psoas, the QL, checking out the lumbar and the cervical paraspinals, can't forget to mention those. Those are fairly easy to deal with. Literally just get on them and move them in all different directions and hold in any tender spot, and that can be very, very helpful. But knowing how to address the QL, teaching patients how to address their own psoas and address their own QL in a way that doesn't further irritate their lumbar spine. Those are all huge things, right? And if you're looking at any type of movement patterns, again, the hip, anterior, posterior mobilizations, huge. If you're working with an athletic population, they do a lot of squatting, right? A lot of those people have a posterior hip capsule issue. If they're missing flexion, internal rotation, and it's got a firm end feel, guess what? Something we can mobilize, right? When we go down to the ankle, like the knee, right? I don't want to skip over the knee. Like if you can figure out and learn how to do some gapping mobilizations in there, where you just create space in the joint and then you move it to end range while maintaining some space in the joint, that's very helpful, right? You can do that for all kinds of things, different flexion issues, different extension issues. Just creating some traction or gapping in the joint is super helpful. And then teaching patients how to do that themselves. And then getting down to the ankle, right? A lot of people are missing dorsiflexion of the ankle. And that, being able to differentiate, is that from the soleus or is that from the talocrural joint, right? And then being able to address it appropriately and make sure you're not making things worse, like I see a lot of clinicians doing. And they think they're being helpful. They've got their placement off and they're actually doing the opposite of what they think they are. But then understanding things like how the distal fibula plays into the ankle mobility and people's ability to move through things like a squat pattern, right? Most people don't even think about that at all. Sometimes people think of a lateral tibial glide, which is not correct. The tibia doesn't glide laterally. It's like literally locked in there, right? But the distal fibula does glide forward and backwards. So you need to be able to assess and address that and teach patients how to take care of these things themselves, right? So now we've got to look at like when and how to use these things and what does it look like as we progress somebody through the different phases of rehab. All right, so the different phases of rehab here, right? I like to think of these as 3 different phases, and most people forget about this 3rd phase. A lot of people don't even get to the 2nd phase in their rehab programs. They just stick around in phase 1. And that is a huge issue, right? So that first phase, that early phase, it consists of lots of education, right? And education is not just telling the patient what is wrong with them. Patient education is, again, empowering the patients with the tools and knowledge that they need to be in control of their own pain and to be able to take care of themselves. So if you have somebody that comes in and they're in a lot of pain, let's say it's a cervical spine patient or a lumbar spine patient even, it really doesn't matter what body part. If they have pain, they come in, you have some good intra-session changes where you then reduce their pain and they come back in and they're just in that same level of pain all over again. And this keeps happening, right? This pain cycle, it's because they don't understand what they're doing, like how the things they're doing is impacting their pain, right? They don't understand how to modify their activities of daily living and the things that they do, the mundane tasks every day. They don't understand how to modify those things to do them in a way that doesn't increase their pain based on their mechanical stressor sensitivity. So lots of education here, right? Focusing on reducing symptoms. That's the early phase. Somebody comes in pain, what do they want? They want to be out of pain. So if you have tools in your tool belt, they can help get them out of pain, do it, right? Combine that with the education at the same time, right? If you decide you want to needle somebody, great, but spend that time that you're needling them, educating them, having conversations, making sure they understand these concepts and how to apply them to their day, okay? And a lot of times these go hand in hand, the education and the symptom modulation or symptom reduction, right? Manual therapy as needed. If you just do manual therapy like we talked about earlier and just randomly do it, you need to have a reason as to why you're doing it. And then I wrote baseline strength because I don't want to say low-level exercises because people might not need low-level exercises. That person from earlier we were talking about that comes in and has pain with back squatting 400 pounds, they don't maybe need a low-level exercise, right? But they might need some baseline strength in a specific area, right? So if we find any areas that need to be brought up to speed in terms of strength or ability to recruit those muscles neurologically, then we're doing that early on, right? Which might look like some lower level exercises, okay? And then as soon as we can, we're jumping over into phase 2, right? And we're getting into where we're now teaching people these self-mobilizations, right? We're teaching them how to care for themselves entirely. We're looking at motor pattern retraining. I forgot the end there, motor pattern retraining, okay? Like, let's look at their squat. Let's look at their pushing, their pulling, their hinging, their lunging, whatever movement patterns that they need for life, their hobbies, their goals, their activities of daily living, their occupation, whatever it is, let's start retraining those compensations out, right? Because if they have knee pain, what are they doing? They're probably shifting to the other side. If they've been doing it for a while, it's probably a neurological pattern now. If they have cervical pain and they go to do a push-up and their shoulders come up, or they go to pull their arms back and their shoulders come up, we need to retrain that so they can move in ways that aren't constantly irritating the thing that's already irritated, right? Set them up for success long-term while keeping them moving and active throughout this phase, right? Throughout the whole rehab, actually. So progressive strengthening, right? And we can hit specific muscles here as needed, but we really want to keep it movement pattern focused, right? Functional movement focused. Like maybe, a lot of people shit on clamshells, maybe a clamshell is a great exercise for someone to learn how to use their side butt and not use their TFL. Or maybe doing basic bridges for that person that can squat 400 pounds, but they don't ever feel their glutes working, and making them understand what it's like to recruit their glutes, right? And then progressively strengthening whatever it is that we need to, but ideally keeping it focused and structured in a way that builds in the movement patterns that they need to work on, not just, you know, doing bicep curls just to do bicep curls because we want to strengthen it, right? If they want to do pull-ups, maybe we do it with chin-ups, right? Maybe we do have some bicep-specific strengthening in there, but we're also doing it functionally with rows, supinated rows, chin-ups, all those different things that also have the bicep as a contributor. Make sense? And then we also want to move into taxing the system, pre-fatiguing with cardiovascular stress, right? Because at this point, they might not be able to tolerate an increase in external loading to challenge their movement patterns, right? We need to make sure that when people are getting back to their workouts, they're getting back to their jobs, or getting back to their hobbies, their sports, whatever it is, we need to make sure that they can maintain movement pattern integrity under fatigue. And if, you know, they want to run a marathon, we're not going to have them in our session go run 20 miles and then see how they're moving, but we can pre-fatigue them with high intensity cardiovascular exercise and then watch how they move under fatigue, right? We might not be able to get that person back squatting 400 pounds because they might not be there, but maybe they can back squat 250 and we can get them doing assault bike sprints, 30-second assault bike sprints as hard as they can and then getting under the barbell. So they're pre-fatigued just like they would be at the end of a long workout, right? So we want to pre-fatigue cardiovascularly using another implement, whatever that is, and challenge those movement patterns. And you know, a lot of times this progressive strengthening, motor pattern retraining, all that stuff, like typically in this stage, it's done slow and controlled with tempos and pauses and isometrics. Maybe they're doing a 10-second squat. Maybe they're doing a 5-second descent on their squat with a 3-second hold at the bottom. Whatever makes sense for them so they can slow it down, learn these new positions, build strength in them. And then maybe we're keeping the movement pattern slow like that, but we're pre-fatiguing, hitting these hard assault bike sprints or rowing or whatever it might be for that specific person, and then getting them to do the same thing, making sure they can control it, right? Which leads us into phase 3. Phase 3 is all about rebuilding the resiliency, right? Increasing the tissue capacity, and most importantly, increasing their confidence. We want them to feel so confident when they leave PT that they can do whatever it is they want to do without any fear or worry of insert body part here, right? Because a lot of times people don't they don't get here. They don't do this. I've talked to patients, not patients, but random people in the gym. There's one person in particular I'm thinking about that they're like, oh, you're a PT? I'm like, yeah, I'm a PT. They're like, oh, yeah, I love PT. I went to PT. I was having knee pain with squatting, and they helped me out. I was like, cool, man. So you can squat without pain now? They're like, no. Like, what? Right? But this is the way patients think, because they never got to squatting. They're like, well, I went there, I stopped squatting, we did a bunch of exercises, strengthened up around the knee, pain went away, so I felt really good. I was like, okay, but did you squat in PT? They're like, no. I'm like, so what happened? Like, well, yeah, I still can't squat, like, it still hurts, but I'm much better now. Like, well, can you squat like with less pain? They're like, no, the pain of squatting is exactly the same, but I feel much better. Right? So they did not rebuild probably their movement patterns, right? They probably missed a whole bunch of stuff. They definitely missed a whole bunch of stuff. And they definitely didn't rebuild that person's confidence in tissue capacity to tolerate the things that they want to do inside of the CrossFit gym. So, this stuff looks like hard workouts in this phase, right? If somebody's a CrossFitter, like, we're going to run them through intense workouts. If they're a weightlifter, we're going to run them through intense workouts. If they're a grandmother that wants to chase their kids around, we're going to run them through intense workouts, right? Chasing grandkids around is a lot of work, right? We just need to make sure that these workouts we're running them through are structured in a way that actually is geared towards the thing that they want to do, right? So they need to be doing heavy loading. They need to be doing fast loading, plyometric loading. They need to work through all of this stuff. So if somebody comes in with knee pain and their buddy's like, hey, you want to go hike Patagonia? They're like, hell yeah, let's go do it, right? They're not like, well, I don't know if my knee will hold up to that. We want to make them do such hard things, pushes them beyond their comfort zone, gets them ideally setting PRs in the clinic with you, and then they're not going to be afraid of anything at the end. Now, these are not 3 independent phases. That's not the way that it works, right? It's more like this, right? Where there's 1, there's 2, there's 3, and there's some overlap here in the middle. Maybe there's certain things that we still need to be working around phase 1 with baseline strength or maybe manual therapy in. And there's other things that we can be working on rebuilding their movement pattern. But ideally, in any capacity that we can, we want to continually push them along here. So there might be ways that we're pushing them early on and having heavy loading, fast loading, while there's other things that aren't getting that and that we're still in the early stages, right? You have to figure this out, and we want to push them along as fast as we can at whatever capacity that we can. Let me clarify there. Not just arbitrarily as fast as we can safely, as fast as we can to help them achieve their goals in a reasonable, responsible manner, right? But just because somebody has one thing that's still over here in phase 1, one thing that's so painful, doesn't mean they can't be doing all this other stuff, right? If that person that has pain with back squatting 400 pounds, maybe they can split squat or lunge, and we can load a different movement pattern really heavy. Hell yeah, we're going to start doing that early on as soon as we can, because we want to keep them active. We want to keep them doing that stuff. We want to start building the tissue capacity, resilience, and confidence as fast as we can, right? We want to build them up in any possible way while we're working the rest of whatever is going on along the chain, right? So if you're not thinking about rehab in these 3 phases, well, time to start, right? And if you're not getting especially into this phase here, like, we've got to set the expectation that is part of the rehab plan, and we have to see it through all the way to the end so we can set patients up for success. So if you made it this far and you don't know who I am, my name is Dr. Roger St. Ange. I go by Doc Raj. I'm the co-founder of the Performance Rehab Authority, where we help clinicians build confidence and just become badass clinicians, because we're on a mission to elevate the rehab profession. I hope you found this video helpful. I'll see you in the next one.